now come to our last presentation, and I'd welcome, it says Kirsty Barnes, Manager Western Health Links Western Health, improving the physical health of people living with mental illness.
Thank you. Do I just push the...
Yep.
This? Hello, it's John Allan. It's actually that one there, yeah. Yeah, change the name. Sorry, there's a mistake in the program. But anyway, my apologies for that, and I think that's why we got stuck on this speaker. So I apologise to my previous speakers who had a bit of their time taken off for me. And as the last speaker, it's my job to bring the session to an end. I know we've had a long session. I want to ask a question which is really, how do you get rich? Because I think old people want to be rich and independent just like everybody else. So it's a really important question. But look, there are a couple of key messages in this talk. This is about the Equally Well movement. Okay, this is about two particular health inequalities that we have. One is that people with serious mental illness die quite young, 25 years on average. If you get that message, that's something about it. And secondly, what are we going to do about it? So that as we get more and more specialised in our physical health care, the integration between the mental health and the physical health care needs to be considered. As we move further and further into physical health care, more and more people who are presenting with the chronic illnesses that people find hard to deal with and hard to change actually have a large mental health problem. We need to get the two together. So if that's the only message you get out of this after sitting here all day, please take that one away. But Equally Well is a group that's now got over 90, it's a group of leaders, organisations, over 90 people, 90 organisations come together in 2015. We have an Equally Well consensus statement. I'll just go through the facts very quickly. For the 25 years, you know that's been replicated in a very nice study in New Zealand of 250,000 people about that mortality rate of twice the population. And this is some Medicare, this is about deaths and about people, so that suicide's a terrible thing, but for every person who dies by suicide, 10 die prematurely from physical health conditions. And the thing that really gets me is around smoking. Ischemic heart disease is terribly overrepresented in that premature death. Now this is some Medicare data, and it's really interesting, I think, again, what I was saying about the integration of physical and mental health. In the blue, these are all various conditions. In the blue are people who have accessed either a mental health Medicare item or have had a mental health prescription, okay? So that, again, in some of these conditions, well over 50 or 60% of people are actually got some kind of mental health issue in their background. And they're the people who are receiving treatment for all of these chronic conditions. Again, like one of the earlier speakers about Indigenous people, cancer is overrepresented in the group of people who have serious mental illness as well. And again, just looking at those slides very quickly, that people with no mental health problems in blue, all people with mental health conditions, and these people have got a psychotic disorder. And you can see that there's this huge overrepresentation. Now, some of the diabetes, some of the cardiovascular stuff does relate to medications. So often people have medications that do help them gain weight, do alter their metabolism, and do make a propensity to diabetes. But a lot of it's also about lifestyle issues. A lot of it's about the way that we actually deal with people, the way that they don't get to see the doctor, they don't get that kind of work. So the interventions that we can make around that, and Equally Well, is around what can we do at every level to make a difference in those kinds of outcomes. And again, another New Zealand report, but I'll skip past the evidence a little bit to say that, again, we've confirmed time and time again that this life gap is actually getting worse, not better. Okay, despite our efforts, we've actually, now that we start to understand it, we're turning over the stones and we know that it's worse rather than better. So this is the history. At the moment, we're in a great policy position. The 5th National Mental Health and Suicide Prevention Plan has taken as one of its 7 targets the physical health of people with serious mental illness, and has actually adopted the Equally Well platform to do that, and is now part of the regional integrated planning process, which I'll talk a bit more about this afternoon, for all PHNs and LHS services to do. So we have a plan, we know the problem, we have a plan, we actually have a method of measuring, but what we need is action. So we have action, we have a lot of commitments, and so what I thought would be really hard would be for state governments to actually acknowledge that this was a problem and commit to action, but in fact state governments are doing quite well in terms of producing guidelines or working hard. And earlier this year Victoria produced their own version of Equally Well about the actions that would be taken, and I'll come to those in a second. But there are 3 actions that need to be taken. There's one which is around setting targets, and that's a national thing, so we have a collection through the national data sets to look at that monitoring. The other is obviously what I'm trying to do today, which is around promoting awareness, just to get that stakeholder database and a communication strategy. We have a website, we can put your actions up, we encourage people to share their actions, we encourage people to learn from each other, run an annual conference, and then we facilitate collaboration through virtual communities, our digital media strategy, and the handles are all at the end there for you to be part of that as well. Again, I won't labour the point about physical illness, but these are the essential elements, and this is where the integration really comes in. There are 6 things that we really need to do to make a difference in this place. Obviously the holistic centred approach, effective promotion, but this one here, care coordination and regional integration across health, mental health and other sectors which enable a contributing life. If we don't do that, we're not really going to change the health of our population. And when you start to look at all that data, it's the people with the mental health problems, the homeless people, and some of the Indigenous people who keep pulling down all that fantastic metric about our population getting healthier. Got to go that way. And the method that we've been using is a Constellation Model, which means that we go out and talk about these things, but we look at what the local action is. The local action might be just something like you have a walking group and you invite people who you might not think to be in your walking group to come out and get a bit fitter. Or you have a way that your practice encourages people who are staying away, who might have a mental health problem of staying away, to come and actually visit the GP. Or you might have a mental health service that actually starts to measure people's blood pressure and make right referrals, or actually teaches the psychiatrist how to prescribe a statin, or how to help deal with someone's early part of diabetes, or employ a dietitian, and so on. So it depends on what your level of activity is, and we have this Constellation Model is really that we have these interventions, we have a shared method of measuring what those interventions are about, we have a way of mutually reinforcing ourselves to feel good about doing that communication, and we have a support backbone team that's supplied by funding from the Australian Mental Health Commission through Charles Sturt University and a group of volunteers like myself and others. And just recently we had a collective action forum in Parliament, which starts to get politicians to take notice, and I think the main thing is about getting all those people to start to take notice of what we're doing. Moving on. So just to talk about some of the local actions, and I think some of these are around grassroots movements, how to get people into surgeries to do that. The Australian College of Mental Health Nurses has really started to make sure that instead of just being trained in mental health nursing, their nurses know about physical health checks. Your experience of health survey, which is given to everybody who enters a mental health facility or has an outpatient appointment in the right sampling way, or everybody throughout, at the moment, Queensland, Victoria, New South Wales, but hopefully throughout the country. In New South Wales, we put in 5 questions about how your physical health is being looked after. The College of Psychiatrists, let's go back, and so on. And this is one particular intervention that I'm involved in in Queensland Health, where we looked at the woeful incidence of smoking in people who present with a mental health problem. And the idea was that we'd screen people, so we actually knew that people were smoking. It was a big start to actually know that was happening. But then to actually do a brief pathway and identified people and get them on a pathway. And we actually paid people. This is a snapshot, obviously. People come to the mental health services. The smoking rate in Queensland at the moment is actually 12%, by the way. So 22% of people in hospital admitted to smoking, 56% of people in mental health units, and so on. You can read the rest of the data there. So we actually paid our services to start doing this, measuring smoking rates and to do an intervention. And in the inpatient services, somewhere. No, sorry, that's the red button. When we started doing that, only under 40% of people who were identified as smokers were put on a pathway. We started setting targets and actually paying the services to reach the target, and then they reinvested that money in education and training for their staff, and they were able to reach a target of nearly 80%. This target was actually set at 75, but they got to 80%. And then we stopped the money, and in fact they've still been able to do it. So very good, and we stopped the money. But what we did was we moved the money to think about, well, what happens in hospital? We'll move it to out of hospital. And so we started a smoke-free in the community, and we actually started paying the community services, community mental health services, to record and put people on pathways as well. And so that's had quite some success, and I won't go into the data about that, but by using a stepwise progression in the targets, we've actually been able to help people to get to that place. And what's even better for us, and we hope that we've presented some of this at Oceania Tobacco Conference last couple of weeks ago, but even better is that we now actually have a method by which we can measure the smoking rate of everybody in the mental health services in Queensland, and so we can actually tell whether, in fact, we've actually had any change, because you know it takes 11 times to quit smoking, and for people with serious mental illness, it can actually take you many more than 11 times to quit smoking. Chair, we're nearly there. It's a good example. So that's the Growing Collaborative, and this is my message. If your organisation's brand is not there, we want you. We want to know what you're doing in this area. A lot of the things that we did today are really doing that. I mean, even helping a person with housing and their legal problems who've got a mental health problem is actually going to make a difference to their health outcomes. So it's not just health organisations. I really think that there's a lot of stuff that we need to do to change this collaborative and feel good about what we're doing. It's now recognised in WHO. There's obviously the health priorities around that, and some of the things that we're doing seem to fit with those health guidelines. So, you know, it's a multiple level. What can people do? Well, so what can each partner do in this space? And what I say is, if you just have one or two people as an individual, what can you do? But if you have a large organisation or a large service, what are you doing, and how are you recording that? And it's now gone international. So we borrowed the name Equally Well from New Zealand. England have now taken it up. 12 countries. We're working hard to get this as a worldwide movement. At the next WPA conference, we'll be doing a seminar on the worldwide movement of Equally Well. And that's my message. Get involved. All the tags are there. Have a look at the website. We've got a conference in May 2000, another one in Queensland, which we just held, so we just missed that. But we're working hard to do that. So thank you very much. Can I go?
Question.
John, as health services, we employ really large numbers of people, and I guess one of the questions I'm interested in is, are you looking at the smoking and other sorts of status and opportunities for our staff?
Yeah. So what we did with that money that we gave the services is actually we reinvested it in smoking cessation training for their staff. So many of our services now have that dual thing, so that the case managers can actually take the message, do that brief intervention. One of the other things I didn't mention that was we actually did a partnership with Quitline to make a mental health friendly Quitline. So we've got preference referrals. Cost me a bit of money, but we've got preference referrals. And but we thought that rather than just putting it out, we actually need to be able to talk the physical language as well. So that reinvesting that money. So the money wasn't, even if you give a service a little bit of money, they'll actually use it really, really well. Much better than people like me will use it. So you give it to the people. Yeah.
Any question at the back?
There's one at the back, Queensland Health. So it's called the QUIT program, QUIT Incentive Payment, and it's been used in the past for a whole lot of reasons. And one of the bits of health economics of it is that the total investment was $5 million, all right, over a couple of years. And it was actually part of a general health program, so that smoking rate in the general wards, it was actually aimed at getting people on smoking pathways in the general wards. And we then argued that because we had such a high rate, that we continued that for another 2 years in the mental health unit. So it's a long talk about it. I don't want to go into all that detail. And so we're now investing $1 million in a year in the community stuff. And the reason we're doing that is that if you look at it, the share for each health service, so for the really big ones, it's like about 80,000. But for the little ones, it's like 30,000, okay? So 80,000 is just one, not even a worker, and 30,000 is not nothing, right? So if we were giving that money out as just a project officer, you wouldn't get much bang for the buck. But giving it this way for a result, we've shown from a public health, from a it just works health economically, that it's actually quite a cheap investment in terms of the health outcome you get. So if you're lucky and you have a good opportunity and a good message, you can sell that to your health service. I'm also, in my day job, a health services administrator. And when you get a good opportunity like that, it's actually worth investing the money. So public health people, get out there and sell it. Yeah.
Any final questions?
Lunchtime, isn't it?
Pretty close.
Thank you. Laura O'Shea from North Richmond Community Health. I just wondered, can you talk about the data and the success of those pathways,
Yeah.
sort of longer term? So are they actually working, or are we thinking more broadly that the Australian government's policy, in plain packaging and things has been more successful?
So look, I think the three. I think if you want to go to lunch. Because if you want me to start talking about tobacco, we could do lunch here. Look, the main thing in dealing with smoking is the price point. Okay, so the taxes. So there's longitudinal data from the time we started taking smoking seriously, which was sort of in the mid-70s. Okay, longitudinal data about the consumptions and the changes, and they relate to price point number one. Okay, that's the number one. The plain packaging and messaging is a little bit of icing on the cake, but it's really restriction of point of sale. It's really pricing that makes a difference. Health interventions haven't made a whole lot of difference. So the smoking rate in Australia has decreased mainly due to people not taking up smoking. All right? Quitting is a really hard thing to do. And we want to get people to quit, but the decrease has actually been people who are smokers have died and they've been replaced by people who don't smoke. All right? But it's the price point. But we need to do everything we can do. And so our job as clinicians is to support that when that price point hits, when that person meets someone with lung cancer or they start to cough or whatever it is, it's our job to be ready because the quitting is really hard. Well, it's not hard at all, but in terms of it takes lots of efforts to quit. And, smoking and the confusion between mental symptoms and smoking, so people think that their mental illness will get worse when they stop smoking, which is not true. It's meta-analysis. We've done published work on that. Not true. So all that's required. Sorry, long talk. Yeah.